Ever heard of double diabetes, hybrid diabetes, or type 1.5 diabetes? In the current time, distinguishing between two major types of diabetes is not straightforward, and the features of both T1D and T2D may coexist within one subject. This state is known as double diabetes, DD. Two main types of diabetes have been distinguished: type 1 diabetes and type 2 diabetes. This classification system is based on various factors that differ between patients with T1D and T2D, such as age at disease onset, degree of insulin resistance, presence of a systematic subclinical inflammatory state, excessive weight, presence of metabolic syndrome, degree of loss of pancreatic beta cell function, presence of specific autoantibodies associated with beta cell destruction, concentration of C-peptide in the blood, and requirement for treatment with insulin to survive. A patient suffering from type 1 diabetes is typically represented as being a young lean person who has lost 90 to 100% of his or her beta cell function and needs insulin treatment from the time that the disease started because of a direct lack of insulin production and secretion. However, an individual with type 2 diabetes is represented as being an older, overweight, or obese person who develops the state known as insulin resistance, which causes the functional failure of beta cells and consequently insulin deficiency. Can be treated with oral anti-diabetic drugs at the beginning of the course of the disease, whereas insulin treatment is needed at a later point in time. The features of both types of diabetes coexist in one subject. This situation triggered the need to discriminate, so-called double diabetes, DD. 1 in 4 patients suffering from type 1 diabetes meets the criteria of metabolic syndrome, according to the National Cholesterol Education Program Adult Treatment Panel 3, and can be identified as an individual with double diabetes. Tup et al. Authors propose the classification of double diabetes patients as type 1 diabetic individuals with at least one type 2 diabetic relative. Gilliam et al. Define double diabetes patients as individuals who were atypical or who had clinical features characteristic of type 1 diabetes and type 2 diabetes at presentation, which raised doubts about the proper diagnosis. Patsili et al. Claim that double diabetes occurs in individuals with clinical features of type 2 diabetes and type 1 diabetes, with a metabolic component outweighing an autoimmune component. Cleland also described double diabetes as the presence of type 1 diabetes and features characteristic of type 2 diabetes. Kietsiroj et al. Defined double diabetes as type 1 diabetes in individuals with a family history of type 2 diabetes, being overweight, with features of metabolic syndrome or insulin resistance, thus highlighting the significance of an indirect marker of insulin resistance, known as the estimated glucose disposal rate. It seems that double diabetes represents a gray zone between type 1 diabetes and type 2 diabetes, and is a continuum of diabetes. The coexistence of type 1 diabetes and insulin resistance involves genetic predisposition, obesity-related factors, and the impact of diabetes treatment. Treatment, particularly intensive insulin therapy, can contribute to weight gain and insulin resistance. The end result is the occurrence of double diabetes, characterized by the coexistence of type 1 diabetes and insulin resistance. The only treatment for type 1 diabetes is insulin treatment, preferably as intensive insulin injections, and must not be changed into other anti-hyperglycemic drugs. But intensive insulin treatment is associated with weight gain, which escalates insulin resistance and leads to higher doses of insulin needed to achieve glycemic targets. Because of that, glucose-lowering drugs commonly used in therapy of type 2 diabetes can be promising possibilities in double diabetes. Metformin added to insulin therapy in type 1 diabetes may prevent declining insulin sensitivity, potentially reducing the risk of double diabetes, while also improving cardiovascular health and safety. Lifestyle changes are also necessary to prevent and treat insulin sensitivity. Diet is an important modifiable risk factor of the development of insulin resistance in T1D, and diet with high protein, low fat, and optimum carbohydrate intake, with increased intake of dietary fiber, may improve insulin sensitivity. Regular physical activity can also be beneficial, as it reduces insulin resistance and daily dose of insulin without influencing HbA1c. These lifestyle modifications should not be underestimated as an adjunctive treatment in double diabetes. Recognizing individuals at risk of, or with double diabetes, a serious clinical issue linked to heightened complications, is crucial. Incorporating assessment of insulin resistance and indirect markers into clinical practice aids in identifying this condition early.